And it's kind of nice because they took the whole safety database from all the trials and summarized everything. I think Paulo are you giving a abstract at EHA this year? Yeah, that, pardon me, just on the transaminitis issue. Again, looking at all the experience across all the trials, so that'll be a really nice summary as well. So here's the trials. The O2 is the first trial after the first in man was done in healthy volunteers. 07, we basically combined it with any drug you can think of that we use standardly. So 232 patients in that trial. And then the third trial is the upfront trial. That's the upfront over age 65, Idela plus rituximab. The 09 was actually the registration trial for lymphoma. And then let's see, the 99 is just simply our continuation study. Patients who are continuing on treatment go on to that. And then that 116, the last one, that's the randomized trial, the rituximab with or without idelalisib. So kind of have a representative patient population here, and you could see the numbers are fairly significant. The early trials, there were different dosing schedules, and then all the combinations. About 700 patients, 59 with CLL and 5 with SLL were treatment naive, so the vast majority were heavily pretreated. Here's looking at the data, the monotherapy patients, and then those used in combination, the demographics here, and the disease types shown here. The majority of the patients are those with CLL. Here's a summary of adverse events that occurred in at least 15% of patients. I'll just point out a couple here. Go into this in a little more detail. So here's that diarrhea colitis. This drug causes a microscopic colitis. It's not the diarrhea that you just heard Michael talk about, where they get a little, you give them Lomotil, end of story. This is not what you see early on. This occurs late, and it's not bloody. But it's just watery diarrhea, and it just does not stop. You can't control it with anti-motility agents. And when you do a colonoscopy, you really don't see mucosal changes, but when you biopsy, then you see the colitis. So it's a microscopic colitis, and actually the PI3-kinase delta knockout mouse develops this exact condition. So that's a big one. Of course, pneumonia. So infections here. What's not shown here, but certainly what's seen, although fortunately not a large number of individuals, is an interstitial pneumonitis. And that can, of course, be life-threatening. So you can see some of that in patients on Idela, and that's something that can occur early. And then in terms of laboratory abnormalities, like ibrutinib, it really isn't particularly myelosuppressive, but of course in these trials, when you start out with patients who have borderline counts to begin with, and some of them tip over into a neutropenia temporarily, but really it's not something that's a challenge in managing patients because it doesn't really seem to be intrinsically myelosuppressive, but there's always exceptions to that in some of the patients. And then finally, the transaminitis, and this is an early event. It's around week 6, 8. It really corresponds to that very rapid treatment response. So it's very different than a traditional hepatotoxicity that might be dose-related. And of course, one would expect to often continue, at least without dose reduction. This happens. You interrupt the dosing. It almost always resolves. And then you can restart, usually at the same dose. And most of the time, not always, but most of the time, you never see it again. So generally, it isn't a huge challenge in keeping patient on the drug. And you don't see it late. You see it in that one time frame. So at least it's somewhat predictable. But you can see here, it's really similar, whether it's monotherapy or combo therapy. This number is probably a little bit low for grade 3 or higher. I think it's a little more now overall when you look at over 20%. Oh, and parenthetically, remember the diarrhea colitis issue? Well, we always talk about grade 3 and higher. Grade 2 diarrhea is not fun. So I think we do a little disservice by breaking things out, at least for that side effect. Grade 2 diarrhea is significant. Here's the time to onset of this first grade 3 or greater diarrhea. And you can see here across the board, median time is 7 months. It's virtually always, at least this condition, more than 6 months into treatment. And I think as Paulo alluded to earlier, sometimes you see this a year later, 2 years later. On the upfront study, I think I have 16 patients, and 15 of the 16 have eventually developed this issue. So it can be a real challenge to keeping patients on treatment. And I think still some of this is still underrepresented, even in this report, because remember, our follow-up, for example, on that 116 study, the randomized study with rituximab, is still too short. The data I showed you earlier with the second interim analysis, that follow-up was a little over 6 months. So I think it's a bit higher than we've traditionally reported. The pneumonitis tends to occur earlier, and it occurred in 3% of patients. And it's a traditional pneumonitis with diffuse findings on chest CT. So here's how some of these AEs were managed. You can see here dose interruption, dose reduction for the diarrhea colitis, dose or treatment discontinuation. But as we've gained more experience, I must say my impression is that this really does remain a challenge to continue patients once it's occurred. Pneumonitis, I would not advise re-challenging a patient. You see some that was in the very early days, but definitely not. And then the transaminitis here, you can see dose reduction, dose interruption, treatment discontinuation, not all that common. And I think we'll have some even better data that Paulo will have this summer looking at this specifically. Here's what happened after re-challenging patients who were dose interrupted with the diarrhea or colitis. 106 patients, 71 were re-challenged. Little more than half were successfully re-challenged. Here's the transaminitis, 109 patients, 82 re-challenged, 3/4 of them successfully. And then the similar data with the rash and the pneumonitis. As I say, I wouldn't focus on this. I wouldn't re-challenge those patients. So that's kind of the overall summary. So I think as we alluded to earlier, the challenge with this drug is not efficacy. It's very efficacious, and you see the same kind of clinical responses that you see with ibrutinib, the same sort of qualitative responses with the adenopathy shrinking, the treatment-related lymphocytosis, etc. But if we have to use it indefinitely or for long periods of time, this is going to be the problem. It's really going to be largely the colitis issue. So I think, and as I mentioned earlier, I think with duvelisib, there's no difference that I can tell. That TG compound, I'm willing to believe that you may not see the transaminitis issues, chemically different perhaps, but gosh, I don't know how to get beyond that on-target effect that was seen in the knockout model. So why should that be any different? But I guess, once we get the clinical trial data, we'll know for certain. Thanks.
The mechanism of microscopic colitis, I mean, so in other words, is there anything theoretically that you could do it to prevent it? So obviously it may be driven by PI3-kinase delta.
Yeah, no, there's no, there have been biopsies, of course, done, and there's no, for example, evidence that well, it's certainly not from CLL being there. And there doesn't seem to be a recruitment of, T cells, a T cell mediated inflammatory response. Other people have speculated on, say, local concentration of drug, but I think that's a little far-fetched. So I just think it may very well be a on-target effect. I don't know.
Steve, sorry. Now, I thought there was some data suggesting there was lymphocyte infiltration. Did they get it wrong? Because
Well, no, so that was Jennifer Brown presented that at ASH. They gave an oral presentation,
Yeah.
which showed dramatic transaminitis in some patients, and I mean dramatic.
Yeah.
And they did some biopsies, and they suggested T cell infiltrate. And to be quite honest, I really take issue with that data. That is not what, that message was. You get this incredible transaminitis, and it's dangerous. You can't re-challenge the patients. I haven't seen patients like that, and I've used it up front. I've used it in the relapse setting. So I don't know the story to that.
this is very important, Steve, because there's been a lot of, what can I say, rumor around following that presentation. I didn't hear it, but I mean, I've heard subsequent. And the implication that I learned was that, in fact, in using it first line, it was even worse. So that
Exactly.
stimulated the whole issue of the immune system of the patients, because T cells, before you treat it, a bit more active. So all that. So you don't think it's actually the
No,
case?
well, so in the upfront trial, the original cohort was Idela plus rituximab, and we had about 50 some odd patients. Susan O'Brien put about 30 patients on. I put 16. So we had 45 of the 55 patients, and we didn't see what they described. And then we had a second cohort of Idela alone and upfront. Didn't see that. And then we've used it in every combination in every kind of relapse patient, and they've just completed a 100+ patient study of relapse del-17p. So you'll have some data from that. So what they presented was striking. I mean, I don't have any reason to doubt it, but that sort
You
of came
haven't
out of
seen
left
it.
field.
I
Yeah.
think it's important. Yeah.
But I think, it is important to keep in mind the disease state. I haven't seen, maybe others, I haven't seen data in upfront low-grade lymphoma with idelalisib, right? It's approved for relapse, but those patients are obviously probably very immunologically different than the relapse. So is that going to be a much more of a problem there? So I think there's still a lot of unknowns. Paulo, your impression?
No, because of course the data on the liver also, I didn't understand them because it was 2 cases of persistent transaminitis, even which never happens, because it is true, it's the only symptom that whenever you stop the drug, it drops the next day. You see the transaminases decrease. While instead for the diarrhea, because probably you are a better doctor than us, when we do the colonoscopy, which means that it's probably late, we don't do it easily, we always see very bad mucosa, and the gastroenterologists always call us and say, oh, is it again another patient with idelalisib, or is it a new IBD diagnosis? Yeah. So in our case, when there is a symptomatic diarrhea, grade 3 and 4, there is always a very clear diffuse mucositis, like an IBD.
Yeah, maybe we looked at patients later because we didn't really recognize what the issue was. But I think the message there is that even if you see normal mucosa with this kind of syndrome, you have to have the gastroenterologist biopsy.
No, that I'm sure, but I want to say that it never happened to us, so I don't know if we do it too late, maybe when we do the colonoscopy too late or not.
And you manage it with steroids. Yeah. And so we've typically used a budesonide Entrecort that they use in inflammatory bowel disease, and instead of oral systemic steroids, which you can use as well. But with the non-absorbables for IBD, patients aren't treated with that chronically. But if you're going to have to treat patients with that chronically, you're still going to see the systemic side effects of steroids. So it's not a long-term solution either.
You know, but if steroids works, it still makes you think it's an inflammatory, I mean, there's some kind of inflammatory cells, which again then gets you, is there something you can prevent, prevent it in a way? I
Don't know.
I don't know.
I mean, I hate the idea of treating a symptom of a drug indefinitely in order to give the drug.
Steve, is there any linkage between the colitis and the few cases of pneumonitis too? Is there some?
No.
Is there anything?
At least, there's a few cases of pneumonitis, but of the patients of mine that had it, they didn't have the colitis. No idea. I mean, when they've done biopsies, like when they combined it with the SYK inhibitors and saw that was the dose-limiting toxicity, it's just the classic biopsy findings of an interstitial pneumonitis.
So, Mark, or actually Steve, has anyone looked at chemokines or cytokines in these cases to see whether or not there's any, or CRP or other markers of inflammation that could presage this?
I mean, just anecdotally, of course, people have measured things like CRP when they occur, and that certainly hasn't been consistently elevated. As far as cytokines, they tend to drop dramatically early on with treatment, but I don't know about any systematic measurement, especially when these events occur.
One question that came up, so I make it public. Whenever there is grade 3 and 4 diarrhea, you have to stop the drug. So
I mean, I do. I mean,
yeah, no, but also, I mean, you wrote a paper on that.
You can continue, but
you wrote a paper. So I would never treat someone with corticosteroid and keeping the drug. So it's better to solve the,
and it's,
to solve
there's
the
no
colitis.
Remember, this is late, so you've already have disease control, so you can reassure your patient, don't worry, stop the drug. Your disease is going to be fine for a while. If you can control the colitis, then you can try to re-challenge them. Some are successfully re-challenged, but I think we have to reassure our patient about their underlying disease, that they're not left without treatment.
If I may add something, because now we are discussing like, diarrhea grade 3 and 4. So these are sick patients. So most of my patients were hospitalized because of that, because the conditions are really are not good. So you want to stop the drug, clear the situation, and then it's never clear if it is really due to idelalisib. You start always thinking about an infection. The gastroenterologist has always his ideas, and so you waste a couple of days always discussing. Definitely, as you wrote also in your commentary, grade 3 and 4, it's better to stop the drug, take your time, and maybe try the...
You just have to tell the patient over and over and over again that it's okay to call if you have diarrhea, don't wait. One of my patients, came in with 2 weeks of diarrhea, even though we told her this, and she had a creatinine of 6 because she was so dehydrated because, she didn't want to stop the drug on the trial. So, we all have patients who have those kinds of motivations, understandably. But if you get it early, then you don't have that problem where they're so sick. Okay.
What is also true, it's not that the diarrhea evolves from grade 1, 2, 3, 4, so it can happen immediately as grade 3, so without any warning.
Yes.
I think in our countries where we don't have so many different clinical trials and so many options to change patients, this will be a hard decision, because if we stop one of these novel agents in our patients, maybe we will have ibrutinib available. If we stop due to an adverse event, we have nothing else to offer them. So,
well, at least in the trials, even when we were doing them, you didn't have to permanently discontinue the drug. So the point is, you're telling the patient, look, it's okay to hold it for now. We're going to manage this, hopefully resolve it, and then we can restart you. So hopefully you have that leeway, even if it's within a trial.
Okay.
Carlo?
You stop the drug when the diarrhea starts. How long do you stay without the drug? Just after the diarrhea became better?
No, I usually,
What is the policy
you,
for
you
that?
treat them and you want them, I think it's always better to really let that symptom resolve. There's no urgency in getting them back on the drug generally for their CLL, because remember, it's late. So I want them to have normal bowel movements. I'll leave them on the steroids, and then I'll restart the drug.
Do you continue with the
Oh,
steroids?
I will
Yes.
for then, no harm. And then, okay, you restart the drug, you're doing okay a week later, great, let's start tapering you off your steroids, see what happens.